Thank you guys for joining. We'll be getting started in about 2 minutes. All right, good evening, everybody. Welcome and thank you for joining the Broward County Alumni Chapter of Delta Sigma Theta Sorority Incorporated. We welcome you to our 2021, the fourth trimester, Exploring Pelvic Health. I am Ashley Gillis, and I will be your moderator this evening. I would like to introduce an amazing group of doctors that are here to increase our knowledge about pelvic floor therapy and services to strengthen the pelvic area. If you have any questions during this presentation, please write them in the chat so that we can get answers following each presenter. I'll start by introducing our first panelist. Our first presenter is a soror of Delta Sigma Theta Sorority Incorporated, Dr. Shoshana Lewis, PT, DPT. She is a pelvic health and orthopedic physical therapist and the founder of Miru Core Choice Rehabilitation LLC in Beaverton, Oregon. Dr. Lewis graduated from the University of South Florida and has worked to gain expertise and knowledge in pelvic health through the Pelvic Health Academy of the American Physical Therapy Association. She is a trauma-informed therapist with a host of skills to help her patients do what they want with who they want without pain and leaking. Our next presenter is Dr. Kavina Parker, PT, DPT, a pelvic floor physical therapist. Dr. Parker attended Florida State University and the Florida Agricultural and Mechanical University, where she earned 3 degrees, culminating with her doctorate in physical therapy. It was during her time at FAMU that she learned about pelvic floor therapy and the impact that this underrated service could make in someone's life. Our final presenter of the evening is Dr. Jaisha Pena. Dr. Jaisha Pena, PT, DPT, is a native of Lawton, Oklahoma. She received her bachelor's degree in sociology from the University of Georgia and her doctorate of physical therapy from the Florida Agricultural and Mechanical University. Dr. Pena has education in pelvic health and rehabilitation for both women and men. Dr. Pena is also a member of the American Physical Therapy Association, as well as the Academy of Pelvic Health and Women Health resident at Brooks Rehabilitation. Please remember to leave any questions that you have in the chat below. And now we're going to have Dr. Lewis take it away.
Hello, everyone. Thank you so much for coming. I want to start with something light and to just get our wheels turning around our pelvic floor. I know this is a foreign subject to a lot of people, but I want to go over some myths and some things that, quite frankly, just aren't true behind the pelvic floor. And some of those myths will get you all to see that a lot more people deal with pelvic floor dysfunction than those who know that they're dealing with pelvic floor dysfunction. So we can go ahead and get started. So I should try to go just in case. If you all can, I know you all can't speak, but if you can raise your hand on the raise hand icon at the bottom, how many of you all either do this, know someone who does this, or at some point in your life, you did this? You went just in case. I'm about to be out for a couple hours. Let me just go ahead and go so I don't run into a problem later. Right. Okay. So that's not normal. That's not what we want to do. If you don't have to pee, don't. If you don't have to have a bowel movement, don't. You're training your bladder to go before it's full. And it's research shows that that's highly correlated with men or women having incontinence later in life and as they get older, because you've trained your bladder to go when it's 50% full or 20% full. And then you'll have issues later because it won't work out well and you'll be dependent on pads or other things. The next slide. I drink less, so I pee less, right? Now, in theory, maybe you might be peeing less, but you're also dehydrating yourself. Your kidneys and your body's going to go through metabolism, whether or not you give it food or water. It doesn't really matter. And so when you don't drink anything, your body doesn't have the hydration that it needs. The process, you're not dead. So the processes of your body are going to be happening regardless. And depriving yourself of water may stop you from leaking, but you shouldn't have to stop drinking water in order to stop leaking. There's ways to continue to have the right amount of water intake as well as control what's happening at your pelvic floor. And the next slide. Sex is uncomfortable. I should just power through. How many of us have done this? Tell the truth and shame the devil. How many of us have done this? If something doesn't feel right, sexual intercourse should not be a painful activity at all, in no way, shape, or form. If it hurts at all, something is wrong. It's not because, oh, I went through menopause, I just had a baby, it's going to get better if I just keep doing it. That doesn't, one, make any sense, and it's just not true. You need to talk to your partner, you need to talk to your OBGYN, go to your pelvic floor therapist so that they can get to the root cause as to why you're experiencing that. There's not one reason for one person to experience pain during intercourse. It can be for a number of reasons, and it's definitely something you need to get looked at. Okay, and then the next slide. I leak a little when I laugh. It just comes with babies and age. This is one of the most common things that I hear. And although that is true and very common, it also could not be so. There's things that can be done so that that does not happen. If you leak when you laugh, although you can probably find a good 100 women that or men who can say that this is happening as well, all of you all need pelvic floor therapy. Okay, next slide. When I'm pregnant, there's nothing I can do about my back pain and hip pain. Not only is this common, this actually infuriates me that somebody will tell a woman that she can sit pregnant for 40 weeks and do nothing about the pain that she's experiencing, which is not true. Having therapy, having manual work done, having things that's going to help you be in less pain while you are pregnant is mandatory. I've been to and heard a lot about what happens in other countries behind being prenatal and giving birth, and this is just standard of care. If you're having hip pain or back pain while you're pregnant, you don't have to wait to give birth in order to deal with the pains that you're having. Some of the pains that you're having may actually make your delivery worse, and you could actually get something done about this and get knowledgeable about what's happening in your body. So next slide. Miralax will fix it. I have heard this a lot from like 30s on up. Miralax will fix it. Miralax will fix it. I just take Miralax and I'm fine. As long as I have my Miralax, I'll be regular. If you are dependent on anything to go to the restroom, there is a problem. Now, all these aids will help you, and they can. And some people drink Miralax all day long and they still don't go. And so the issue is not something that Miralax can fix. It's something that you need to go to your healthcare provider to fix. So if in order for you to have a bowel movement, you take Miralax, you use an enema, you have to drink a tea, you have to do any of these things in order to go, and without these things, you're unable to go, that's an issue. Okay, I can't have sex when I'm pregnant. This myth is also wrong. You can. And I've met a number of people who already know this. This was more taboo, I would say maybe 10 years ago, but it's still very true. No matter how far along you are in your pregnancy, unless you have some outlier reason as something else is going on with you that's outside of the norm, you can have intercourse when you are pregnant. And again, it should not hurt, whether you're pregnant or not. Sex after menopause. Yeah, right. So after menopause, we go through a number of changes. Hormones are all over the place. Some are higher than others. And that causes changes to your pelvic floor, which may cause you to have pain with intercourse. A lot of times I meet a lot of patients who tell me, well, I just have to deal with this. I'm going through the change. And so this is just something I have to deal with. I can't have sex because I'm in pain and my partner cannot have sex because they need a pill. No, right? We can help you with pain and in intercourse, and after menopause, you can have intercourse. There's no reason for you not to. You just need to get yourself to a point and understand why you're having that discomfort and then deal with it so that you can live your best life. Next slide. Pooping once a week is normal. No, it is not. The presenters later on are going to get more into the details behind what's normal and what's not, but you should not be pooping once a week. And if that once a week time happens again because of Miralax, the other slide that we had, or enema, you don't wait until you just feel so bloated that you can't take it anymore. You take the enema, you take the Miralax, and now you've gone to the bathroom. Absolutely not. And even if you're not on Miralax and you're only going once a week, that is not normal, and it can be fixed. Okay, I had a C-section. My pelvic floor is fine. No, no, no. And I see my other presenters on here are just like, no, like these are the things we hear all the time. Your scar where your C-section is sitting right over your bladder, like literally directly over your bladder. Changes in your urination, bowel movements, sexual function after C-section arguably might just be a little bit more common than having a vaginal birth. So many things can go wrong. You need scar mobility. You need someone to go in and make sure that the changes that you're having at your bladder or during sexual intercourse isn't as a result of how your scar healed. A lot of people just have the scar, they live with it. It hurts for weeks and weeks when you cough, when you laugh, when you do all of these things, and then miraculously you think it's just going to go away and just going to get better. And that's just not the case. If your scar line isn't straight, if it's wiggly, if it hurts, if you have nerve sensations every time you touch your scar, even to this day, that's something that a pelvic floor therapist can help you to deal with. And it doesn't have to be so. All the women in my family have lazy bowels. I can't fight genetics. And I can't help you fight genetics either, but I can also help you go to the bathroom. And so you might have some people genetically do, like they do have intestinal issues or bowel motility issues that have happened to their mom, their aunts, their grandmothers, and all of these other peoples. And in the African American population, that's something that I hear all the time. But I'm here to tell you, your mom, your aunt, your grandmother, and all of them could have done something about it as well. So although it's genetic, you can get help for it. Next slide. A little straining never hurt nobody. A little straining hurts a lot of things. You can be causing hemorrhoids to be worse. You can be causing micro tears in your rectum as well as your rectal opening. You could be causing too much pressure to be in your abdomen, which can lead to things such as prolapse and other things. And my other presenters are going to talk about that. So if you are straining, that's not normal. To have a bowel movement does not mean that you sit on the toilet for hours and strain. And if you are straining, that doesn't mean that you take Miralax or a stool softener so that you don't strain. You get to the root of why you're straining. Your pelvic floor muscles may not be functioning properly, and that's the reason why you're straining. So just like any other muscle, if your hamstring was tight, if something was going on with your knee, you would go get it looked at and you would deal with the muscles responsible for that issue. It's the exact same way with your pelvic floor. But pelvic floor muscle dysfunction presents not always like a hamstring pull. It will present as changes in bowel, bladder, maybe back pain, or pain with intercourse. All right, only women have pelvic floor dysfunction. I feel like in another slide, I might have touched on it a little bit, but that is the furthest thing from the truth. I see men every day, every single day. I see at least 2 men that are dealing with pelvic floor dysfunction. Erectile dysfunction is not always caused because of medications or because of other underlying systemic health concerns. It could be because of simple pelvic floor dysfunction that needs to be dealt with a pelvic floor therapist. You have men who have back pain that's persistent, that won't go away. A lot of times you have issues at the pelvic floor. I also have men who feel like their pelvis is crooked, who I see all the time for these issues, who don't know how to load their pelvic floor. Men and women both need pelvic floor therapy if they're experiencing issues in that area at all. Next. All right, so having pelvic floor dysfunction is related to sexual promiscuity. This is one that I'm hoping, if you don't remember anything else I say today, this is not true. I have people in my office who have never engaged in sexual intercourse, who have issues with bowel and bladder. There are people, men and women, who may have had one partner, no partners, whatever they decide to do, that have pelvic floor dysfunction. You do not have to be sexually active to have an issue with your pelvic floor. You could have changes in your stress in your life. You can have changes that happen in any parts of your life that cause you to experience changes either in the bathroom, at your pelvis, throughout the day. If it doesn't feel right, it's not right. If you're having difficulty doing something as natural as going to the bathroom, it's not right. And so that's it for my slides. And I'm going to turn it back over to Ashley. I hope that we did get a few questions in there because I know certain things I'm saying kind of is flipping your entire thought process of maybe how you grew up and certain beliefs you had. But yeah, that's it.
Okay, that was awesome. Thank you, Dr. Lewis. We do have a couple of questions. One is pelvic floor dysfunction hereditary?
Would say no. In the African American population, there's certain trends that you see more in certain ethnic groups than others. But I've met people who have pelvic floor dysfunction whose parents didn't, grandparents didn't, and nobody even knows how to tell them that what's going on with them because they don't know anybody who's experienced it. And I've met people who, like I said, that lineage of mom, grandmother, aunts, and everybody are dealing with the same issues. And so some of the underlying causes as to why you have pelvic floor dysfunction may be genetic. However, the pelvic floor dysfunction in itself is not.
Thank you. The next question, can pelvic floor therapy be effective in treating endometriosis?
So I think someone's going to talk a little bit about endometriosis later, but endometriosis is, I call it the angry pelvis disorder. And so the lining of your pelvis, or the endometrium of your pelvis, is having lesions on it that's causing you to have pain. And so that in itself, no, we're not going to stop you from having endometriosis. However, if you think about something that hurts you and what your body does when you're in pain, you clench up, you tighten your muscles, you try to guard yourself because you're experiencing pain. Sometimes the pain that's associated with endometriosis, especially if you notice it's getting worse and worse and worse as time goes on, it has to do with the changes that are taking place in your pelvic floor. Imagine like a Charlie horse that you never do anything about. And so if that muscle has made changes as a result of your endometriosis, we can help you manage that pain, and we can help you get your pelvic floor muscles out of a high sensitivity state, so that at the very least you're experiencing pain that's more bearable.
Thank you. Up next, we'll hear from Dr. Parker.
All right, good evening, everyone. I'm excited to talk to you more about the pelvic floor and what it is, and more about just what we can do as pelvic floor physical therapists to get you more educated, so you can, be more proactive and be empowered to treat your own, not treat your own pelvic floor, but in order so that you recognize when you need to seek out that treatment. Okay. All righty. So what is a pelvic floor? We've been talking about pelvic floor since we got on. So the pelvic floor itself is all the visceral. So think of the organs, the neurovascular, your nerves, your vascular system, your blood supply, and your myofascial system. So your muscles, then the fascia and the tendons and ligaments that connect everything. Okay. So that's all contained within the bony pelvis. So that those hip bones that you see, that you sit on, that is your pelvic floor. Now, what we're talking about when we say pelvic floor dysfunction, so any of those structures can be affected, but what we're treating are the muscles typically, okay? So the pelvic floor muscles is that muscular layer of the pelvic floor, okay? Next slide, please. Alrighty, so I like this picture because in the colored part, you see the pelvic floor muscles. So if you're looking from the top down, okay, you're going to see those pelvic floor muscles, and you can see they're all different colors. So even though they're separate muscles, they all work together to lift and contract the pelvic floor, okay? So its muscle is kind of like a sling shape, and they kind of lift and contract. So they're supporting those pelvic floor organs, they're supporting your stability in the pelvis, okay? So they're contributing to that, all right? So now this slide is actually looking from the bottom and up, okay? So if you were to cut you in half, we're looking in half this way rather. We're gonna look from the bottom up. So as you can see here, this is more so the pelvic floor. You see that there's nerves, there's blood supply, the muscles there, okay? Even some tendons and ligaments you can see. So from the top down, you have your clitoris, your urethra where your urine comes out, you have your vaginal opening, and then your anus, okay? So as you can see, it's fully supplied with nerves and blood vessels. So just like any other muscle in the body, the pelvic floor muscles can act and feel just like other muscles, okay? So this is what we're looking at. This is what we're treating when someone comes in to see us and they say, hey, something's going on with my pelvic floor, okay? All righty, so I really like this slide because you can see the back muscles, you see the abdominal muscles, you see the diaphragm at the top, which separates the thoracic cavity from the abdominal cavity, and its job is to help you breathe. And then you have the pelvic floor at the bottom. So I like to think of all these muscles as the core, okay? And so as you change throughout your lifespan if you become pregnant. Think about how the body changes, okay? So you need all of those muscles to give you good stability. So when you become pregnant, think about how that skeleton is going to change. Those abdominal muscles are going to stretch. The back muscles are going to dip in. You're going to kind of walk with a little waddle maybe. So think about how that's going to change things in the stability and structure and function of your core, okay? You might develop back pain. You know, there's weakness across the core. There's weakness in the pelvic floor. Maybe you start having a little leakage. So different things may happen as you go through changes, you know. So not just pregnancy, but different areas of pain because that stability is breaking down, okay? So not only, like I said, not only pregnancy, but think about what's happening to the bones themselves, okay? So just really want you to think about if you're having back pain. I think Dr. Lewis mentioned this earlier. Just because you're having back pain, it could be affecting other structures. So as physical therapists, we're going to look at everything, okay? We're going to look at how the back is reacting, how the core is reacting. And I know Jaisha is going to get into that a little bit later too. So let's go on to the next slide. Alrighty, so what is pelvic floor dysfunction? We've been talking about pelvic floor dysfunction, and so that basically is any disorder of the muscle which may affect the organs, or conversely, the pelvic floor organs are dysfunctional and it may arise problems in the pelvic floor. Okay, so those pelvic floor organs are the bladder, the bowel, the reproductive organs, okay? So in our females, we have our uterus, in the males, we have our prostate, okay? So when these organs become dysfunctional, it can affect what's going on in pelvic floor or vice versa, okay? All right, so why is this important? Why are we here today? So 1 in 4 women suffer from pelvic floor dysfunction. So that is just a fact, okay? So if 1 in 4 women are dealing with pelvic floor dysfunction, you know, think about the women you know. Out of all of them, 1 in 4 may have some type of pelvic floor issue. Alrighty, so there are currently about 28.1 million women affected with some type of incontinence, okay? And that number is expected to grow. And then think about this, 50% of women receive no education about pelvic floor exercises or different types of conditions that can arise before, during, or after childbirth. So we have an issue here. There's no education, there's no conversations being had. And so if that's not happening, how can we empower ourselves? How can we better ourselves, okay? And things are now becoming normalized, okay? Because if you know someone else who has the same issue, you can go ahead and click the next one. If you know someone else who's having the same issue, then that becomes normal. You know, if they say, oh, you know, I just deal with it after my child, I just deal with it. You know, I'm older now. So it's just something we go through. And if one person who doesn't know tells someone else who doesn't know, tells someone else who doesn't know, then it becomes normalized and people begin to think, oh, you can't treat it, you can't do anything about it. So then no one's going to seek help for it. Okay. So we have to change the way we're talking to one another, and we have to be educated to do that. So go ahead, next slide. So now, Black women specifically and pelvic floor dysfunction. So I was able to pull up some research about racial and ethnic differences in the knowledge regarding pelvic floor dysfunction, the preventative and curative treatments for it, and also similarities and differences in experiences, perceptions, and care-seeking behaviors, okay? So overall, Black women and women of color are less knowledgeable about conditions and treatment options for pelvic health, okay? There are different perceptions regarding pelvic floor, okay? There's difference in understanding and difference in care-seeking behaviors amongst African American women. Okay, there's confusion regarding urinary incontinence, its meaning. What does it mean when someone says, I have urinary incontinence? What does it mean? How does it happen? There's a lack of knowledge there. So there's also barriers to healthcare. So people who don't have health insurance, or a means to getting there, just different things may come up to affect why Black women, women of color, are not seeking care for these issues. And so all women in general in these research articles came across as embarrassed, and they are isolating themselves, and that's also going to prevent them from seeking care. Okay. Another reason they're not seeking care is that they're putting other people first. If you have a family, if you have, you're taking care of your parents, you're taking care of your children, you're taking care of everybody else but you. Okay, but you. Okay, so we have to be mindful, if we are, putting everything off until, we're putting everything off for ourselves until this, until that, until that. So if we keep doing that, eventually we are going to kind of get worse and worse and worse until we have to deal with it. So you don't want to get to that point. Okay, so and instead of living in shame and fear and isolation, having decreased sexual desire and activity, you can go and get help for these types of issues. Okay. And so I really, enjoy talking about this topic with you all tonight. As a Black woman, I personally did not know about a lot of pelvic floor disorders, until I got to PT school, and, I learned about prolapse. I learned about, different reasons that urinary incontinence is happening. And so I'm happy to share with everyone. So now we can be educated and we can educate others. Okay. So now what is happening? Symptoms of pelvic floor dysfunction. So what will we feel when we have the pelvic floor dysfunction? Urinary incontinence. Okay, so that is leakage, uncontrolled leakage of urine. Okay, urinary frequency. That means we're going too often. As Dr. Lewis mentioned before, we're not supposed to go all the time. We should actually be going at a healthy interval is every 3 to 4 hours. Okay, 3 to 4 hours is that healthy window. At the very least 2 hours. Okay, but that healthy interval, that's that 3 to 4 hours. Urinary urgency, that strong sudden urge to urinate. Okay, that pelvic organ prolapse, that's when your organs actually they descend and they kind of dip into the vaginal canal, and it can actually protrude outside of the body. Okay, so in order to prevent that from getting worse, please go see a pelvic floor physical therapist before the surgery, before a rest surgery is recommended. You'd be surprised. You would really be surprised how much this helps. Okay, pelvic pain. Pelvic pain is so diverse. It can be pain in the back. It could be pain in the abdomen. It could be pain in the actual pelvic floor. It can be pain in the testicles for my men. Various different types of pain when you're having intercourse, when you are sitting, standing. Pelvic pain is going to be a symptom of dysfunction. Constipation, we talked about that constipation. If you're going once a week, that is no good. Normal ranges of constipation can be from anywhere between 3 times a day to every 3 days. Once we pushing past that 3-day mark, we gotta kind of rein it in. And then even if you are going every 3 days consistently, how is your stool consistency? Is it hard to pass? We have to look at these things, okay? And then also urinary retention. Are you holding urine so long that your abdomen and your stomach actually start to hurt and you can see it distending? Okay, so those are going to be symptoms, some symptoms, that's not an exhaustive list, but some symptoms of pelvic floor dysfunction. Okay, so now what are we looking at? When we actually are talking about the muscles are either going to be, for simplicity purposes, there can be some middle ground, but they're going to be underactive, so they're hypotonic, so they're weak, or they can be hypertonic, so they're strong, tight, maybe not strong, but they're tight and dysfunctional. Okay, and just because you're tight, the muscles are tight, does not mean that they are healthy and strong. Okay, Alrighty, so as you can see in the pictures, the strong, healthy pelvic floor muscle has the organs lifted and supported, while the more weak and hypotonic pelvic floor muscles, those organs are starting to drop down, okay? Alrighty. So now, specific underactive pelvic floor muscles and their symptoms. So when your muscles are underactive, so those weak, hypotone, low tone pelvic floor muscles, you can have urinary incontinence. Urinary incontinence could include stress urinary incontinence, such as if you're getting up from a seated position, if you're coughing, sneezing, or even exercising. Okay, that can mean stress. That can mean a stress incontinence. And then there's urge urinary incontinence. So that urge is as you get that strong sense that you have to urinate, and you're going to the bathroom, you're trying to get there, but you're having some leakage before you quite get there. And then you can have a bit of both. It can be mixed. Pelvic floor PT and pelvic floor dysfunction is not always black and white. You can have stress and urge. You can have urge and pain. You can have a combination of things, okay? So remember that. So pelvic organ prolapse, what's happening there? Cystocele, rectocele, uterocele, urethrocoele, any part of those organs, they can start to descend. So I like this picture here. It shows that it actually can occur in stages, okay? So that's what I was talking about before. It can actually protrude from the body. So we want to catch it before it gets to that stage 4. We don't want to see stage 4s, okay? All right, and then also fecal incontinence can be a sign that you're having some underactive pelvic floor muscles, okay? Alrighty, so the next slide is going to talk about the overactive pelvic floor muscles, those high tone muscles, those overly tight muscles. So as you can see, again, we have urinary incontinence, okay? So that urinary incontinence can include urge incontinence and stress incontinence, and also urinary frequency. So I put that in asterisk because just because you're having frequency doesn't mean you're having incontinence, okay? But I did kind of lump that under there. Urinary retention can also be a sign of overactive pelvic floor, and pelvic pain. We are usually going to see a lot of pelvic pain with our overactive pelvic floor muscles. So vaginismus is actually more of the muscle spasm. So and we talked about, just because you're having pelvic floor dysfunction doesn't mean you've been promiscuous. So that vaginismus I often see in young people who've never had partners, and older people who've never had partners cannot even insert a tampon, and we think that's, some of us, we take that for granted. Like, I've been inserting tampons since, I've had to go swimming and do these things. So think about that. These women are having those types of issues. So then you have vulvodynia. So think of your vulva, that outside area of your vaginal area, okay? So that area can become painful. Mostly it's like burning, itching. Could you imagine just nonstop burning in that area all day? You're get uncomfortable. Just everything is always going to be tight to try to protect you, but that's actually maybe causing things to be a little worse. And then dyspareunia in general is a painful intercourse, okay? And that could be a combination of that vaginismus and vulvodynia. It's just painful intercourse there, okay? So now you know a little bit about what you might experience if you have some pelvic floor pain, okay? Or pelvic floor dysfunction. Alrighty, so now we're kind of going to start tying this into, well, what does pelvic floor PT, what does that do for pelvic floor dysfunction? So as pelvic floor physical therapists, we're going to identify and treat that underlying cause of pelvic floor dysfunction. So we're going to figure out and help you figure out what is the state of your pelvic floor muscles. Are they weak? Are they too tight? Is there a combination of both? Okay, are your back, your abdomen, how are your legs looking? How are all of those things connected? Okay, So in general, pelvic floor physical therapists improve patients' quality of life by providing conservative and effective treatment for issues arising from the pelvic floor. But yes, I think that, but what does the research say? Alrighty, so does pelvic floor physical therapy really work? I say yes, but the research also backs that up, okay? So there's a lot of evidence that says yes, it works for pelvic floor dysfunction, okay? Go ahead. Alrighty, so it should be a first line, it's low risk therapy, and it has really high success rates. A lot of times I hear horror stories about women who have gone through surgery after surgery after surgery, and as they start to work with me, they're like, oh, why didn't I do this first? Why couldn't I have done this first? Or they tell me, I had a friend, they got that bladder lift, that bladder sling, and they're still having leakage. And it's like you've already undergone a very invasive, very expensive surgery when you could have come to pelvic PT first, okay? So in a huge clinical review, they looked at some different pelvic floor dysfunctions and their outcomes with pelvic floor physical therapy. So with stress, that coughing, sneezing, getting up, exercising, urinary incontinence, 8 times more likely to have a cure or improvement with pelvic floor physical therapy. For urge incontinence, women have fewer episodes, okay? Pelvic organ prolapse significantly reduce the symptoms. And those symptoms can vary from woman to woman, okay? Vaginal pain, significant improvement in the pain scores, quality of life scores, and even sexual function scores, okay? So yes, pelvic floor therapy does work, okay? And so, and it's even in some countries, before, during, and sometimes after, women are being referred for pelvic floor physical therapy. And I can't wait until it's like that here. But it should be recommended during and after childbirth, especially to help prevent those issues such as urinary incontinence and postpartum sexual dysfunction, and even pelvic organ prolapse, okay? So I believe that is it. If you have any questions, I'd love to answer them. Back to Ashley.
So we do have some questions.
All
This
right.
question, it's pretty long, but it's a good one. This question has to do with vaginal prolapse.
Okay.
I'm 7 months pregnant. If signs of vaginal prolapse show during my second trimester at a 1 to 2 mild level based on doctors and disappears after 3 days, what is the likely possibility of it not reappearing after a vaginal childbirth of a third child? I have never experienced anything like this with my other children born vaginally.
They said it was a 1 to 2. It was like a stage 1, 2.
1 to 2 mild level.
Okay. So what are the chances so I know I'm getting the question right. What are the chances of it coming back after the birth of the second child?
Of the
Or
third
the
child.
third child. Okay. So pelvic organ prolapse is kind of multifaceted. So the symptoms of pelvic organ prolapse, like I said, they can vary, but you'll feel maybe some pressure, maybe some burning, depending on what exactly is prolapsing. Now, depending on how the birth of the child occurs, if there's a lot of pushing, if there is improper breathing, it is a chance that it could come out again, okay, come down again. So yes, is there a chance? Yes, especially with all of the force that's going to happen around the pelvic floor, the muscles that have to stretch, all of that. Are there things you can do to help prevent it from getting worse? Definitely. If you're not having issues with it now, I would definitely recommend getting into see a pelvic floor physical therapist when it, I guess, depending on maybe 6 to 8 weeks once you're after you've delivered. So any other panelists want to take that one or have any other suggestions? Okay.
Okay, so we'll go to the next question. If I perform Kegels daily, will that prevent pelvic dysfunction?
It depends on the kind of, well, if you don't have any dysfunction, it maybe not daily, but to keep the pelvic floor muscles engaged, that might be beneficial to an extent, but you don't want to overly work them. And if you are having some kind of dysfunction, if you don't know exactly what's causing it, pelvic floor exercises such as Kegels can actually make it worse. So just be mindful of what how your symptoms are responding to what it is that what exercises you're doing.
Thank you. We have 2 more, then we're going to go to the next presenter, but you guys can keep dropping your questions in the chat and we will get to those. The next question is, could vaginal dryness be related to pelvic floor dysfunction?
Yes. Yes, it can.
And the last one before the next presenter, what's the best way to strengthen the pelvic floor after childbirth?
The best way to strengthen the pelvic floor after childbirth. Well, it really depends. It depends on what else is going on. What type of issues are you having? Did you have an episiotomy? Did you tear? How is your abdomen? How's your back? It's going to vary. But definitely, performing a Kegel exercises strengthen the pelvic floor. That is what they do. Now, if you're having other issues, any kind of pain, any kind of like instability, if you're having some separation between the abdominal muscles, that diastasis recti or diastasis recti, depending on tomato. So it depends, but you don't want to do anything that's going to worsen your symptoms. Okay, so it's actually best to get in, see a pelvic floor physical therapist after you have those children. Okay.
Thank you. And now we will hear from Dr. Pena. You're muted. You're muted. You're muted.
Thank you, Ashley. Okay, I'm going to talk about pelvic floor evaluation, examination, and what to expect when you are expecting pelvic floor physical therapy. If you can go to the next slide. The evaluation examination is going to look possibly a little different depending on the therapist you see and depending on what you're going in for. But generally, we want to know about your social history. So what do you do for work? Because a lot of times I see teachers and nurses that have a little bit different needs than other people because their bathroom times look a lot different than some of ours. What do you need to be able to do? Do you have a job where you need to lift a lot, or are you at home doing things where you need to lift a lot? And then also asking about your reproductive history. So how many pregnancies have you had? Have you had abortions? How many live births have you had? Have you had any miscarriages? Also trauma. And trauma could be in the form of a birth trauma. It could be in the form of sexual assault. It could be physical abuse. It could be emotional abuse, but it all ties in to what your pelvic floor may be doing. And then just a general systems review. So when we're looking at your pelvic floor, we're not just looking at your pelvic floor and your pelvis. We're also going to look at your back, like Dr. Parker and Dr. Lewis talked about earlier. We're also going to look at general posture. We're going to look at how you're breathing, how well the joints around the pelvis move. So that includes your hips, your hip joints, your sacroiliac or SI joints, your pubic symphysis, any joints that could be directly involved with your pelvic floor. And then also, like Kavina just talked about, looking for diastasis recti, especially when you are postpartum. And if you have a postpartum assessment and nobody checks you for diastasis recti, either ask them to or hightail it to a pelvic health physical therapist so that they can look at that for you. Go ahead to the next slide. So surrounding a pelvic floor assessment, I wanted to highlight that consent is huge. So when you go in for pelvic health physical therapy, nothing is going to happen that you don't want to happen. If it does, leave there. Find someone else and report whoever you were seeing. And that's also true with any other physician you see or any physician you see. So your OBGYN, if it's something you don't want, it shouldn't be happening. I think people get this misconception that like, oh, well, this person has the degree, so I have to listen to what they say, but it is your body and you do have autonomy over it in every situation. So an external exam of your pelvic floor may be just looking at the skin, seeing what the skin looks like, if it looks like it's irritated at all, and then touching around the labia, touching near the perineum, which is that area of skin between your vaginal opening and your anus, just to get an idea of what that tissue feels like, whether or not there's tenderness or what we call trigger points. Another way we assess the pelvic floor is via an internal exam. So that exam could be internal vaginal or internal rectal. And you've got 3 layers of your pelvic floor. So typically, depending on what you come in for, the pelvic floor therapist is going to try and assess all 3 layers and the left and right side, just to make sure that they're functioning the same way. A rectal exam could look like examining the tailbone or touching the muscles, same thing, left and right side. Possibly even touching the prostate to see what it feels like for the male population. Another way to assess the pelvic floor, especially when you're talking about someone who has a lot of pain or is pregnant, because in most states, I don't think anybody is doing internal exams on pregnant population without special clearance, is surface electromyography. So that is the picture here where you can see the purple and pink on the computer screen. It gives you a way to see what your pelvic floor is doing. And then next to it, there's like a white pad and there are like little silver prongs on top of it. Those are the external electrodes. And then the one that's just like more cylindrical, that's an internal vaginal electrode. There are also internal rectal electrodes. But however you're hooked up, it displays what your pelvic floor is doing on the screen. So it gives you a better idea of what you can and can't do with your pelvic floor than just, okay, I'm going to touch here, I'm going to touch there, and I want you to Kegel and I want you to relax. It gives you more insight. And then real-time ultrasound is another method of biofeedback that's, I think, becoming more popularized, but it's kind of expensive. So if they don't have it where you go, it's okay. But it's usually across the abdomen. And research does show that in healthy persons, better transverse abdominis engagement, that was that front abdominal muscle that Kavina showed. Dr. Parker, I went to school with her, guys, so I can't help it. But Dr. Parker showed earlier, and also the pelvic floor. So you can kind of visualize it and get a better idea of how to contract or relax those tissues because you can actually see them. You can go to the next slide. So some commonly used tools that your therapist might ask you to get. I'm gonna start from what is my left on the computer screen. So under commonly. Those are vaginal dilators. You can see they come in different sizes. Vaginal dilators might be a tool you use if you have something like vaginismus. It just kind of stretches the tissue. And then if you keep going towards the right, the pelvic wand. It's also typically used for pain, but it's easier to use when you're trying to pinpoint specific muscles. So if I say, go in about to the depth of your first knuckle, and then at 12 o'clock is where I want you to work. It just gives you that ability to pinpoint those muscles that might have some trigger points or be causing some dysfunction. And then the next one are the Kegel weights. So you insert them into your vagina, and it's still a form of biofeedback because you've got something there that you can feel that gives you feedback. Okay, yeah, I'm actually squeezing. Or okay, yeah, I'm stronger than I was before because I can do the purple one. And when I started, I can only do the hot pink. And then that very last one is a perineometer. And that one might be a little bit dated, but depending on where you go, you might see something different. But you insert it either into the vaginal canal or the rectum, and you squeeze and it shows the pressure or how much pressure you can hold with. So it's a good tool to use, like if you're trying to monitor strength or if you're trying to work on endurance, you can kind of see, okay, yes, I'm holding right here. For the most part, though, the perineometers have been retired in favor of the biofeedback with the computer. All right, you can go to the next one. And so after you've had all of that assessment inside and out, you start working on your goals. And so as physical therapists, we always try and write SMART goals, so specific, measurable, attainable, relevant, and time-based. I like to think of it as who needs to do what, by when, and how well, under what conditions, so that we're getting the full picture of everything that you need to be able to do to be successful. But after those goals are made, and for me, this is going to be like, if you don't remember anything else I say, when you go to physical therapy, and it's not just pelvic health, it's for anything, we are going to do our part, but it is not our jobs in entirety to fix you. It's our job to give you a bunch of tools, and it's your job to kind of follow through. Because you see your physical therapist 1 or 2 hours a week, it's not the same as the amount of time that there is in the week. So you really do want to, whatever exercises you're given to do at home, be diligent about them, because I promise you they make a big difference. And so when Dr. Parker was talking about how well physical therapy, pelvic floor physical therapy works, I was like, yeah, and truly pelvic floor physical therapy is one of the more, let me say, people have higher satisfaction with pelvic floor physical therapy than they do with some of the other specialties, because you really can get so much out of just a little bit. So whatever the plan is, after you've done all that assessment and you make your goals, like I want to be able to sit for 45 minutes without pain in my tailbone. Great, that's the plan, that's the goal. But then this is how we get there, and you've really got to work this is how we get there. If you don't, you kind of end up stuck in the place that you've always been, and nobody goes to physical therapy for that. Yes, you can go to the next slide. Okay, so I am going to have us practice a few things. I will say this, just to reiterate what Dr. Parker said earlier. Kegels are not for everybody. So I'm going to talk about how to do a Kegel, and you can try it, but I am not telling you you need to start doing Kegels every single day, because I don't know what your pelvic floor can and cannot do. And if you can't get your pelvic floor completely relaxed, doing Kegels will not serve you. It will make things worse, typically. So you might start to have symptoms that you didn't have before if you're doing Kegels when you really shouldn't. But I'm going to lead with diaphragmatic breathing. And if you see, yep, you can start the video over. This video here is showing, it's a real-time ultrasound showing what your pelvic floor does with normal chest breathing. This is typically the breathing we're all going to do throughout the day. And you can see how the pelvic floor moves a little bit. And here it changes to belly breathing or diaphragmatic breathing. And you can see how much more length you get in your pelvic floor. And I think Dr. Lewis and Dr. Parker would agree with me when I say lengthening your pelvic floor, or how well it lengthens, is just as important as how strong it is. You can't have one without the other. It's like, if my arm is stuck right here, that's not a functional elbow. You can't do nothing with this elbow. You got to be able to straighten it out just as much as you got to be able to bend it for it to be a functional, strong muscle. But anyway, if wherever you are, you can put your hands kind of on your lower ribs or even on your tummy. And you're going to take a breath in through your nose, but you want to think about keeping your chest nice and relaxed. So a lot of times when we breathe with the muscles in our neck and it lifts our rib cage this way. That's not what we want. We want the diaphragm to flatten out. It's going to give pressure down through all of your, intestines and stuff into the pelvic floor and give you that nice lengthening that we see in the video. So hands on the lower ribs, you're thinking about as you inhale, belly comes out, ribs flare away from each other. And I tend to tell people, like, even thinking about breathing into your back, because there's space there and it will expand as you take a nice deep breath and your diaphragm flattens out. So wherever you are, whatever you're doing, just in through the nose, out from the mouth. I tend to say in through your nose like you're smelling a flower, and out through your mouth like you're blowing through a straw. And that's diaphragmatic breathing. The second one I wanted to teach you guys is the transverse abdominis contraction. That's the deepest layer of your abs that co-activates with your pelvic floor. So typically, if you're going to pelvic floor physical therapy, this is a muscle that you will at some point discuss. So you're going to put your fingers, 2 fingers, on your pelvic bone, and then kind of go just to the inside of your pelvic bone. It should feel softer. And you're always breathing. So always breathe. Nothing we do is going to involve breath holding. You're going to think about pulling your belly button in and then towards your face. So in and up. And you should feel that muscle jump into your fingers. I'm doing it now and I'm talking. So if I'm talking, you know I'm breathing. You should be breathing and then relax. And same thing again, belly button in and towards your face and relax. And so that's a contraction of your transverse abdominis. Again, I'm not telling you that you necessarily need to go around doing this all day because I haven't looked at you. I would really want to know, like, okay, what's happening with this? What's happening with that? Before I told you, like, yes, this is your home exercise program. Go do it and be fruitful. So the last, and I guess you'd say, I don't think anybody gets out of pelvic health physical therapy without doing a Kegel at some point, whether it's the end because you had to work on relaxing first, or the beginning because you just needed to strengthen. So when you're thinking about doing a Kegel, the biggest thing is breathe. And then you don't want any other muscle activity. So if you squeeze your glutes, you'll see yourself go up and down like y'all can see me doing right now. So that's not the muscles you want. If you're squeezing your thighs in together, those aren't the muscles you want. If you're pulling your tummy in a lot, that's not the muscle group you want either. Everything else should be very relaxed. At any given moment, you could be doing Kegels and nobody should know, unless you do kind of that dead eye look, then people might know. But otherwise, when you're contracting your pelvic floor, no one should know but you. So you're thinking about right where your vaginal opening is, or if you're a male, you're thinking about your penis, maybe bringing your penis up towards your belly button or lifting your testicles inside your body. For women, you're thinking about either pulling your vagina up and in, or that same contraction you would do if you needed to pee and you were going to hold it. But again, nothing should happen. We shouldn't see anything. All you should feel is kind of the up and in, right at your labia, right at your perineum. If you are confused and you're not sure you can do a Kegel, one thing you can always do is look. So hold a mirror to your vaginal region and Kegel. Everything should come up. If something's going out, you're pushing. And that's not the right thing. If you're not seeing any movement at all, find a pelvic health therapist. But definitely, you can look and see if you have an issue with looking. You can always touch. You can touch right at your perineum. Even if you just touch right at your labia, you'll still feel the pull up and away from your hand. And again, if you feel something coming down into your hand, you're going the wrong way. The research on the number of people that cannot do a Kegel the right way would blow your mind, because I know everybody talks about Kegels all the time. And so everybody thinks, yeah, I'm doing them. But not always. The last thing I want to say to add to my kind of home exercise piece is, I know this is the fourth trimester. And I guess we never defined fourth trimester. It's, I think, the 12 weeks after you have your baby is typically how it's defined. And in other countries, there is so much care for postpartum mamas. It's not just you go to your 6-week checkup and they say, okay, bye, go take care of your baby. We as pelvic health therapists really look forward to being able to take care of you after your baby, for being able to help you after you have your baby. The one thing I will say is, a lot of times women postpartum put so much focus into their family and their children that they forget about themselves. And so then it's 20 years later and I'm still leaking, or I still got this same pain that I had when I had my babies. And we can still help you, but healthy, happy mommy, healthy, happy baby, always, always. So if you're pregnant now and you think you could use it, go see a pelvic health therapist. Heck, if you don't know and you just got questions, go see a pelvic health therapist. But definitely postpartum, go get your pelvic floor looked at. And if everything's perfect, at least you can get a home exercise program to kind of make sure you're back strong and functional as you were before you had your baby. But if everything's not, you'll be in the right place to get the help you need. Thank you.
Thank you so much. So we have questions. The first question, are yoni eggs a good tool to strengthen the pelvic floor?
I think they can be. I don't have a bunch of experience with yoni eggs, but my understanding of them is that they're not much different than the vaginal weights.
Okay. Next question. How often should someone do a vaginal self-check, and how do you do it to see if areas are weak?
Okay. So,
And
I
anyone
have never been asked that question, and I'm gonna tell you the truth. I don't think I know the answer. Does anybody know the answer to that question?
What'd you say? A vaginal what?
A vaginal self-check.
Like looking
How
at yourself?
often?
like
Looking at
do you
yourself?
know if, I'm assuming, how do you know if you have these weak muscles? Like, is there a way for you to check on your own? Like, should you feel
Oh.
Okay. So a lot of times, if you have pelvic floor weakness that's significant, you're gonna know because you're gonna have symptoms. So if you can't hold it and you need to get to the bathroom, pelvic floor weakness. If you have pain, even though the muscles are tight, still pelvic floor weakness. If you're leaking when you cough or sneeze, pelvic floor weakness. Typically that's going to be the way, but if you wanted to self-assess, you could insert a finger into your vaginal canal, Kegel, see how well you can hold it, see what the endurance is like. I like to work till people get up to about 10 seconds, but you could do more. See how well you could do a quick Kegel and relax. Like, can you get completely relaxed? There's a lot that could go into that. There's a lot that could go into it. But the truth is, if you have any question about whether or not your pelvic floor is healthy, I'm still going to say find a pelvic health therapist, because I can't truly give you the best advice for your pelvic floor because I haven't seen it. And so it's tough. You know, it's not quite the same as like, oh yeah, I can do a breast exam and I know what I'm checking for, because you don't quite know what you're checking for when you're looking at your pelvic floor. But just know, if anything is painful, if you've got weird bladder or bowel habits, chances are your pelvic floor is not as strong as it needs to be.
Thank you. This question is for any one of the panelists. Should the anus simultaneously contract while performing Kegels?
I'll answer it if that's okay.
Yep, go ahead.
So when you think about your vaginal opening and your rectum, that skin that's in between, I call it, it's a perineal body. I call it the belly button of the pelvic floor. And so your pelvic floor is a bowl, like Dr. Parker said. And so when you're doing the Kegel correctly, it should literally look like you took a kiss and made it come backwards. Okay. And so that will make your rectum go opposite. So if you're looking at yourself with a mirror, you should see, okay, when you take a deep breath in or you're increasing the amount of air and pressure in your pelvic floor, you should see that come out at you, kind of like if you went with your mouth. And then you should also see the reverse happen when you do a proper Kegel. I, like I said, agree with what everyone else is saying. So that your rectum, if your rectum is not moving, that is indicative of more happening. But because it's a bowl of muscles, you may have more control or more voluntary control of what's happening at what's going on around your vagina, and not as much voluntary control of what's happening at and what's going around your rectum. And so I would then ask the question, okay, you may be seeing something that doesn't look right. Are you constipated? Do you have burning when you're urinating? Are you having discomfort during intercourse? Can you not sit for long periods of time? Do you rock in the chair and have discomfort at your butt? Does your butt become numb after sitting for a period of time? And all of these things add up. And I wouldn't want you to try to put the pieces together yourself, because I have people who have done that, and everybody comes to me and apparently has cancer in their heads or whatever is going on. And so you have to really take the time to say, okay, something doesn't look right, and that should just be your call to action.
Yes, don't believe the internet. Don't get your advice from the internet, because truly pelvic health therapy is not one size fits all. Everybody is different and everybody has different goals.
Okay. What causes pelvic weakness? Anyone?
So that can be a multiple, like what causes your pelvic floor to be weak. Like any other muscle, if you don't use it, you lose it, okay? So if you're not actively engaging the muscles, they can become weak, okay? There can also be trauma to the area. So think about childbirth. What's happening to the muscles? They're getting stretched out, okay? And so sometimes that healing process that comes following childbirth, which is why that fourth trimester is important, okay? So those muscles, they have to heal and then also become functional. So that function, like Dr. Pena said, you know, they have to lengthen and contract, okay? So if you're not able to contract, you know, then we're going to have to work on strengthening. But if you're not able to lengthen, we're going to have to work on that also. So sorry I kind of went on a little bit, but basically weakness can happen from different things. Okay.
Thank
Can I
you.
chime in on that for a second?
Yes.
When we speak about trauma, especially in our community, we feel like trauma is only childbirth. And it's true, that is a trauma. But if you're someone who has an overactive pelvic floor, I like to use the example of, like, if a puppy was to get in trouble, they would cower. They drop their head and they tuck their tail under themselves. And we as people do that as well. You just can't see our tails. A lot of trauma we experience: high stress jobs, abusive relationships, poor marriages, issues with our family members. You hold your stress here as well as at your pelvic floor. If you're somebody who clenches at your jaw often, if you're somebody who always can't get enough massages to get this area worked out, your jaw is a reflection of what's happening at your pelvis. And so those muscles that are overactive and weak, what got you there? A lot of times your pelvic floor therapist has to discuss some hard things with you and go down some roads that may be painful for you, because to get to the root of what's happening and pluck it, you have to learn how to manage your stress. So we work a lot with mental health counselors and a lot with therapists that can help you unpack what's happening up here so it can stop affecting what's going on in your pelvic floor.
Okay. Do I need a referral from my physician to see a pelvic floor therapist, physical therapist?
Depends on what state you're in. But in Florida, it's a direct access state. So you could show up and be seen.
Yeah.
It's the
Does
same in
running,
Oregon.
go ahead, Dr. Lewis.
It's the same in Oregon. It's a direct access state.
Okay. Does running contribute to pelvic floor dysfunction, or does it strengthen the pelvic floor? Anyone?
Yes, 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 no, and yes again. That's a very mixed question. I'm a runner, and so a lot of times, if it's very common for runners to laugh about the fact that in mile 2 or 3 that they pee themselves, that's not a functional pelvic floor. Something's wrong. Um, you're actually putting a lot of pressure at your pelvic floor when you are running, which it's designed to be able to do that. But you can't say I'm a runner, so I know my pelvic floor is healthy. That may or may not be the case.
Okay. Does prenatal pelvic floor PT help reduce the risk for perineal tearing during labor? Yes, the answer is yes, guys. How long does it take before seeing results with the pelvic floor physical therapy? Physical therapist.
How long does it take to see results?
Yes, I guess that depends on. Go ahead.
I've had patients, their second visit, they told me they didn't think they were going to come back to their second visit. And they were so happy with what we were able to accomplish after their first visit that they're like, I'm a believer now. But granted, their issues might not have been as severe as someone else's. So I can see someone from 3 to 6 months, maybe sometimes up to a year or more. It all depends on what the issues are. But with every time I get a patient coming back into the office, I ask, okay, what's different? What do you feel like you still feel is problematic? So we're kind of always addressing things. Okay, so one thing might get better, then we're on to the next. Those SMART goals that we set, we are trying to hit these goals and get you prepared to have life after physical therapy. Okay, and something that I really enjoy about physical therapy is that we're not seeing you so that you can be with us for years and years and years. We want to give you those tools. We want to give you the education that you need in order to maintain the success and the goals that we've achieved in physical therapy.
Okay, how does biking, stationary or road, impact the pelvic floor? Anyone? Dr. Lewis?
Good one. So sometimes biking doesn't affect the pelvic floor at all. It just depends on your body's designed to move and to be active. And so I'm very leery about an all or nothing type of answer when it comes to things. But if you are a biker and you notice that you're having numbness in your saddle region or pain in your saddle region that is persistent, or it's not, you feel it on the bike and then you come off, those nerves that Dr. Parker was talking about that's in your pelvic floor, you're literally sitting on them. I have bikers, and my avid bikers, they're not going to get off that bike. And so there's strategies that we can show you if you are a biker to help unload the pelvic floor while you're doing the activity, but you could be exacerbating an issue if the bike makes your symptoms worse. But if you enjoy biking and you have no pain, then it's not an issue.
All right, we have 2 more questions and then we're going to close out. How will pelvic floor treatment affect my fitness routine?
So fitness and pelvic floor physical therapy. How will it affect your fitness routine? Now, I'm not quite sure. I can kind of tackle this from 2 different angles. Are we going to change how you exercise? Depending, so if you have something like a diastasis recti and you're doing a particular exercise and it's increasing that diastasis recti, we might modify that. So if that's the where you're going with that, how's it change the exercise in that way? That could be one way. But now, as we give you exercises for pelvic floor and you're already exercising on your own, I like to start, as you get stronger, I'm going to have you incorporate pelvic floor exercises into what you're already doing. So you're not having to do, you know, multiple sessions of exercises all day or all throughout the week. Okay. And once you get strong enough, you know, you don't have to do pelvic floor exercises every single day. You know, you can do once or twice, maybe 3 times a week, just as if you're working out your body. Okay. So it's not anything that has to be done all day, every day, you know. So just be mindful that as pelvic floor physical therapists, we're asking you about what you do, what you enjoy doing, your occupation, you know, what do you need to be able to do? What does your pelvic floor need oh goodness, what does your pelvic floor need to be able to do to support your life, to support you, to give you that good quality of life that you want to live? So pelvic floor exercises, they don't necessarily have to change your exercise routine, but we may modify.
Okay, so now we have 2 more questions left. One, if I plan on having more children, is it best to wait until after I'm done having children before seeking pelvic rehab?
No.
Do it now. Don't
No.
wait.
There's a that question that came around about the perineal tearing and all that. When your body needs to, no pregnancy is the same. Most people who've had children or multiple children know this. There's never a time that's too early to prepare for what your body is about to go through, and someone who can guide you through those changes. There's a lot of things that go on during pregnancy that women just throw away as oh, I'm pregnant, that must be from pregnancy, or I'm pregnant, that must be from pregnancy, and not knowing that there's strategies and things that can be given to you while your child is growing and things to allow you to expect it. So if you're on baby 1 and you're planning on 2, or you're on baby 2 and you're planning on 3, and you're experiencing any of these changes, you need to go whenever, just go.
And last question, this is for everybody, why do you think that if an ACL repair takes 6 to 8 weeks of rehab, why is it that one visit at 6 weeks following childbirth considered sufficient?
Because men don't have babies. And because our healthcare system is not up to par for us to be a first world leading power. Because if you look at what's happening in England, if you look at what's happening in Finland, like if you look at what's happening in Australia, like physical therapy is the standard care, and psychotherapy is the standard care after you've had a baby. So yeah, we're working on it though. Email your senators, write your congressmen, and the Academy of Pelvic Health Physical Therapy is actually right now throwing bodies together, trying to mount a huge task force for 4th trimester advocacy. And it would be nice to have some moms or future moms on the side of that.
All right, so that's it for our questions. Thank you so much to all 3 of our presenters, Dr. Parker, Dr. Lewis, Dr. Pena. You guys did an amazing job. Anyone that is dealing with any of these symptoms that were mentioned throughout the presentation or issues, please, please, please see a pelvic physical therapist. If you have any questions that you would like answered, our presenters have dropped their contact information in the chat below. Once again, thank you guys for joining us and have a great evening.